Now, the last speaker would be Dr. Sanjay Mehrotra, who is again ACE cardiologist and interventionalist, who were one of the pioneers to start the TAVI program in the country, and he works in a very busy center in South India, in Bangalore, Narayan Hridyalaya. So, Dr. Sanjay, over to you.
So, nightmares, of course, is part of the game, and as far as complications are concerned, they are much more in the beginning of our experiences of TAVR, and maybe we have become better in the understanding about what not to do and how to do, and that's one reason our complication rates have come down. So I would show you two nightmare cases, and although they were, one of them was a proctored case, and I think we, as I said, that our experience have gone up. We usually finish our TAVRs in about less than an hour now, and completely percutaneous with no anesthesia. So I'll straight away go to the patient presentation, and this is a 90-year-old gentleman who was first seen in an outpatient, and he was in congestive cardiac failure. He required admission and stabilization, followed by evaluation for contrast CT and angiography, and he was planned for a TAVI. He was a bicuspid aortic valve with an annular diameter, and I think probably I used a 29 valve. He was a tall gentleman. So we usually get an access from the contralateral side to have antegrade puncture. And you see we are trying to cross the valve. The valve is extremely calcific. You can see the calcium there. We will do a crossing of the valve. And now we are putting a pigtail, which is just the usual technique, followed by a curved wire, which I think in this case was a Confida wire. It was, I don't use Confida anymore. I usually use Safari. And what you will see here while deploying that, of course, we are pacing, but there's no movement of the heart. The heart is completely stopped. And so this is quite a nightmare when it happens, and you see a hand comes. And when the hand comes, you know what I mean by hand coming. Hand means the cardiac massage started. And in all that concern, you lose the axis, which is because suddenly the table gets moved and the wire gets pulled out many times because the person who's going to do the massage says, move away from the image intensifier. And when you move away, sometimes the people will, pull the table quickly and the wire would be pulled out. So I'm trying to cross the wire at that time. And the best thing to do in such situation is, besides you have the backup of, we do it in hybrid lab, you have the backup of ECMO, you have the backup of surgeon, but still these are things which you have to do very quickly. And the best thing is to deploy the valve, because we have already pre-dilated this valve. So now this valve is being deployed during resuscitation. There's cardiac massage going on, and we deploy the valve, and of course the massage is going on this thick wire, and ultimately you see that the heart starts moving again. And this is over at about 15 minutes because you could do all this very quickly. And luckily, and this was an evolute valve, now patient starts moving again, but output is a bit low. You see the aorta doesn't empty very well. So we decided that we put a balloon pump in this patient just to sort of offload the ventricle. And you see the balloon pump there. Now this patient is shifted back to the CCU. I spoke to the patient, and as I said, that it's very important in our country, especially to speak to the family about the risks of the procedure. After 8 hours in the evening, the patient developed a sudden EMD with no cardiac output, and the echo shows a large pericardial diffusion. I took him to the cath lab again, tried to put a pericardial tapping wire, but there's no movement of the heart at all, and the patient died finally. Now, what happened, and I need probably a lot of us will understand that whenever you do this massages in a very stiff wire, even if you try to keep the wire in the central position of the ventricle, there is always movement of the chest, which causes the wire to cause a perforation. And that perforation is a LV tear most of the time. And most of the time, the wire perforation of the LV or the tear is a very linear tear and these patients do not survive. And the first learning was that sometimes in certain patients, even a balloon dilatation is good enough to cause a problem. And then what do? You can't get into a very calcified valve without balloon dilatation, pre-dilatation. And resuscitation is most commonly the usual cause of perforation. But the important thing is that these things will happen to you. And I think it's important that we discuss that there is a potential of complication, which you have to tell the family and be prepared. If you have not done that and it happens by chance, then you are got a sorry figure and you have to give all kinds of explanation. So this was a learning that in old people sometime it is possible this will happen. Resuscitation is possible. What happened to this patient while pre-dilatation? I have no idea, but it is possible during the pacing. Patients just don't come back because the ventricle have no reserve. These are old people. He was 90 years of age. They don't have any reserve and the patients many times will die. I'll show you one more case, which is a case of a horizontal aorta. This was a Proctor case, and we were in the process of learning. This is about almost like, I would say, 8 years ago. This was a 8-year-old gentleman, which was a short individual. He was taken for a TAVR for a transfemoral route and using a 29 Medtronic evolute valve. There were some difficulty in advancing the valve across the aortic arch into the ventricle, and let's see what happens. You see, this kind of a shape is there, and we have got a buddy wire inside the left ventricle in the pigtail. We actually put one more buddy wire, and ultimately you will see that the valve is going inside with some difficulty, but you're putting so much of pressure. I think one of them was even tried with a Lundekust wire. And the pigtail also had a stiff wire. This is a horrible aorta. But ultimately you are able to deploy, but what you see what happens to the ascending aorta. I'm sure that everybody can recognize that there is a type A dissection, which is not surprising. And see the second one. It looks horrible. Now what you do, and what I could have done, is what I learned from this case. This is a type A dissection. Now you get panicked, and even the proctor got panicked. They withdrew the valve, and that was a mistake. We should have deployed the valve. We should have taken care of this dissection later, because now we are leaving the aorta which is not opened up. It is possible to put a dissection stent in these patients. Of course, that is not there, but then unless there is a stroke, this dissection can wait to be treated next day, which we did not do. So my learning was that I should have deployed the valve. Why did I not deploy the valve? You panic, and you also don't get any support from somebody who has not had these experiences as a proctor. So of course I treat dissection all the time. So I was hitting on my head that why did I not think of just deploying the valve and later on take care of the dissection? So the procedure, of course, was abandoned, patient stable after informing the family. And obviously our surgeons do Pental all the time. He was taken up for the surgery, but he died after the surgery. So what should I have done? I should have deployed the valve. The dissection could have been tackled using a dissection stent or another later surgery. And I could have used the snare because I do it all the time now. What you do, you put a snare, take the wire through the snare, take the wire and the balloon and the snare together and deploy the valve, because the snare helps you to do this very comfortably. Now, we don't have that learning at certain time, and then we get into complications, but we are wiser now, and such things I will settle differently than what I did that time. I'll stop sharing, and I'll probably invite some comment from the audience or some discussion on this. This was my 2 horrible cases, which I lost. I've not lost many. We do average about 2 to 3 TAVRs per week these days. I done one this morning. We finished in about 40 minutes. I started at about 9:20 and I was done around 10:30. So we have become pretty good now, but not 10 years ago. And we have learned from other experiences and each other's experience while attending these meetings. And the complication rates definitely have come down drastically. And I think this is the usual learning curve. Of course, we get it there, but we get it sometime. We don't get it and we get into trouble.
Thank you very much, Dr. Sanjay. And that was truly two very good informative cases and a lot of learning there.